Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We start section 7. Yes. Peace, YouTube. Section 7 of this healing magical book, cardiovascular monitoring and supportive therapy. Chapter 26, page 393. Peace, YouTube. Oh, this is going to be so good. Chapter 26. The physiology of circulation and perfusion. Gas exchange at the pulmonary level, external respiration, demands the presence of adequate pulmonary blood flow. However, external respiration is of little value to the organism unless adequate internal respiration, gas exchange between blood and tissue, is assured. In other words, respiratory homeostasis demands adequate functioning of the lungs, heart, and circulatory system. The process incorporating all these factors is referred to as cardiopulmonary function. Airway pressure therapy is designed to support pulmonary function and external respiration. Unfortunately, its application can threaten the maintenance of adequate circulation and perfusion. For this reason, the principles of monitoring and maintaining adequate cardiovascular function, circulation, and perfusion must be appreciated by the respiratory care practitioner. The physics and physiology of circulation and perfusion must be mastered if one is to comprehend the clinical assessment and support of cardiovascular functioning. Defining circulation. A simple example of circulation mechanics is a system in which a pump forces fluid through a rigid tubular system that eventually empties the fluid back into the inlet of the pump. Figure 26.1. The flow is determined by a basic relationship known as the law of flow. Flow equals delta P over R. The term delta P millimeters Hg represents the drop in pressure from the output of the pump to the input. R represents the resistance in the circuit. In this simplified model, the conduits are rigid and therefore resistance remains constant. The pump must supply adequate force or energy to the fluid to overcome all the factors tending to impede the flow. Thus, flow or circulation through the system will be directly related to the capabilities of the pump. Note that a prerequisite for adequate circulation is the presence of enough fluid to fill the system. A schema of the human cardiopulmonary system, figure 26.2, is composed of two pumps in series, ventricles, each of which supply the necessary energy to propel the fluid or blood through the respective vascular conduits, systemic and pulmonary. In general, cardiac output depends upon the pump capacities of the ventricles and the adequacy with which blood is returned to the ventricles. Resistance varies with the geometry of the vascular components, contractile alterations of vascular smooth muscle, changes in blood viscosity, and presence of valvular heart disease. Since the systemic circulation nourishes the vast majority of body tissues, it consists of a more extensive vasculature than the pulmonary circulation. This normally results in a systemic resistance 6 times greater than pulmonary resistance. See figure 26.2. Therefore, with each contraction, the left ventricle must work approximately 6 times more than the right ventricle to accomplish the same flow. All right, we're at page 395, and here is 20 figure 26.1, a simplistic model of circulation mechanics. The pump forces fluid to the flow out and circulate through the conduits. P1 represents the pressure at the pump outlet. P2 represents the pressure at the pump inlet. R represents the resistance of to flow in the conduits. So here we go. Thank you. Welcome, YouTube. Peace. Yes, we are reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So there you go. As you see, 26.1 and 26.2 is right underneath. And I'll read this caption. Miss says, schema of circulatory mechanics in the human cardiopulmonary system. LA equals left atrium. RA equals right atrium. LV equals left ventricle. RV equals right ventricle. SCB equals systemic capillary bed. PCB equals pulmonary capillary bed. The numbers represent mean pressures except in the ventricles where systolic and diastolic pressures are noted. And this is very key, right? We have 4 chambers in the heart. You have the right and left ventricles. You have the right and left atrium. Peace, hi, it's Harlow. Welcome to the YouTube book reading. All right. So this is figure 26.2. So you'll see the right ventricle and right atrium, left atrium and left ventricle. And then what you'll see is the pressures 130/85 in the left ventricle and 25/10 in the right ventricle. This is very key. Peace, everyone. Much love. All right, so here we go. This is figure 26.2 of Clinical Application of Respiratory Care, second edition, 1979 yearbook, Medical Publishers Inc. And again, when we master ourselves and we know ourselves, right, we can master our world. We can help others. So this is why we're giving this information out here for free. You know, thousands of dollars, people preparing. What? We prepare in ourselves first. Have that balance, right? All right, here we go. Myocardial function. Page 395 in the middle. And we're taking notes on this. This is a very key part, all right? I'm going to express it. Circulation in the human cardiopulmonary system may be considered as the flow of blood through a series of conduits resulting from the energy imparted to the blood by the ventricles. Therefore, ventricular output, cardiac output, depends on 1. Pump capability of the ventricle, or myocardial contractility. 2. Return of blood to the ventricle, preload. And three, presence or absence of factors impeding outflow from the ventricle or afterload. Myocardial contractility. Myocardial contractility may be conceptualized as the force developed while the ventricular muscles shorten. At present, a true measurement of contractility in the clinical setting is not feasible. However, changes in the contractile status may be inferred through careful clinical evaluation and serial hemodynamic measurements. An improvement in myocardial contractility is referred to as positive inotropism and is usually associated with an improved physiologic milieu, e.g., improved oxygenation status or normalization of pH, or the administration of positive inotropic drugs, e.g., isoproterenol, dopamine. Yeah. A decrease in myocardial contractility is referred to as negative inotropism and is usually associated with a deteriorating physiologic milieu or negative inotropic drugs, and well as certain toxins and anesthesias. Ventricular preload. Peace, YouTube. Welcome. What's up, everyone? It's a beautiful day. Happy Saturday. We're gonna sing "I Love You" in a minute. Well, I'm just gonna read this next page, and then we'll let you go for the rest of the day. Once you have a wonderful Saturday. Ventricular preload. In an isolated myocardial muscle, preload can be thought of as a degree of stretch imposed prior to contraction. Such stretching in the intact heart results in an enlarged end diastolic volume, or EDV. In general, then, increased EDV is correlated with an increase in ventricular preload. Under normal conditions, and the end diastolic pressure, EDP, will vary with the EDV. Early studies on isolated heart revealed a relationship between EDP and cardiac output, stroke volume, known as the Frank-Starling relationship, figure 26.3. This relationship demonstrates that within limits, increasing the EDP preload results in an increased stroke volume. However, beyond a given point, there is no longer improvement in cardiac output as end diastolic pressures are increased. This relationship exists on an infinite family of curves in which changes are determined by such factors as circulating hormones, autonomic stimulation, and the general physiologic milieu. In the adequately functioning heart, pressure dynamics are such that in the absence of atrioventricular valvular abnormality, the mean atrial pressure will provide reasonable reflections of ventricular and diastolic pressures. Thus, measurement of atrial pressure provides an clinically reliable reflection of ventricular preload. Ventricular afterload. Peace, YouTube. What's going on, y'all? Hi, it's Heart Love. I wish you were all well on this beautiful Saturday. Ventricular afterload refers to the force against which the ventricle must work to eject blood. The primary afterload component is the resistance within the vascular system. However, valvular disease and increased blood viscosity also will result in increased impedance to the ejection of blood. Generally, an increase in vascular resistance leads to an increase in arterial blood pressure. Therefore, changes in mean arterial pressure may be used to clinically reflect changes in ventricular afterload. And here's figure 26.3. Okay. So you'll see on the vertical bar, it says stroke volume. And then on the horizontal bar, it says end diastolic pressure. And as you see, A is right in the middle. B curves upward higher, and C curves lower, as we were just speaking in the text. It says the Frank-Starling relationship. A represents a normal heart. B, a heart with increased contractility or positive inotropism. And C, a heart with decreased contractility or negative inotropism. Peace. Oh, highest heart low. This is figure 26.3, as you see. All right. Be sure I get it right. There you go. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition, 1979. We're in the 26th chapter, the Physiology of Circulation and Perfusion. And we just entered the 7th section of this masterful book. So we're doing it. I mean, we started from page 1. And look, we're about to hit page 400 together, reading books on this peaceful part of YouTube where we read books and learn from masters. So I'm Master Fitness Trainer Uriel Riley. Thank you so much for being here with us. Hi, it's hard. All right. Page 397 at the top. Body waters compartments. Body water compartments. The human vascular system is composed of dynamic conduits capable of contraction and expansion. Thereby, vascular resistance and blood volumes are variable. The multiple factors affecting intravascular volume are essential to comprehend before the factors involved in venous return can be understood. The adult human body is composed of 40 to 60% water by weight. Fatty tissue contains less water than other tissue. Thus, total body water by weight varies inversely with obesity. Ding! We have to drop a pin there. Breathe that in. Go ahead. Breathe it in. I've never been overweight. I'm so grateful and thankful. My whole entire life. Stay in optimal shape. Every AM, I'm up running. I'm doing almost 175 to 200 push-ups. Every day, I'm stretching and breathing to my body. Every part. See, that's why you feel that peace from me. I've cultivated it in my body, in myself. Masters are always going to be mastered. Right? Yeah. Fatty tissue contains less water than other tissue. Thus, total body water by weight varies inversely with obesity. Males have approximately 60% of normal body weight as water, females about 50%. Figure 26.4 illustrates the total body water, or TBW, is distributed between two major compartments: intracellular and extracellular. The extracellular compartment is in turn divided into two subcompartments: interstitial or extravascular and intravascular. Since water can move across cellular membranes and capillaries, osmosis, all body compartments maintain an equilibrium with reference to water. The intracellular compartment contains about two-thirds of the TBW in the adult. Distribution of the remaining one-third is normally 75% in the interstitial compartment and 25% intravascular or blood. The RBC mass, although intravascular, is considered part of the intracellular fluid compartment. The larger protein molecules are primarily contained within the intravascular compartment. Yeah, we dropping some gems in this book read. Oh my goodness. I'm gonna let you guys go in a little bit. Just a few more lines. All right. Wow. Woo! Gem time for real. The larger protein molecules are primarily contained within the intravascular compartment. The small amount of protein that enters the interstitial space is removed by the lymphatics and returned to the blood. The colloid osmotic pressure, or COP, exerted by proteins, see chapter 29, plays an important role in maintaining intravascular volume at the capillary level. Representative values for blood volumes are listed in table 26.1. All right, here we go. This is figure 26.4, and it shows the ideal body weight equals 100%. And then it has the breakdowns in smaller boxes and distribution boxes that show 60%, 20%, 40%, 5%, and 15% interstitial. 5% is intravascular. Extracellular is 20%. Intracellular is 40%. Total body water, or TBW, is 60%. It says normal distribution of total body water expressed as percentage of total body weight. See text which we just read. All right, this is 26.4. Down at the bottom. Thank you so much for reading with us. Amazing, amazing, amazing. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, second edition. Thank you so much for the likes and subs. We're pushing towards 500 or 600 now. It's unbelievable how far we've come. I'm so grateful and thankful for all of you. All right. And this is table 26.1 in blood volume. It shows normal body weight. Males, 7.5 to 9.0 in the range of percentage normal range. All right. And then normal, and then the mean body weight is 7.5. And then milliliters over kg is 75. And remember, this is blood volume, okay? And then in females, it's 6.0 to 7.5 is the normal range. And then mean is 6.5. And then milliliters kg over kg is 65. Small table. Here at the top of page 398. See. Thank you so much for reading with us. Highest heart love. All right. So here we go. Absolute hypovolemia. Absolute hypovolemia is defined as a decrease in blood volume from the patient's normal volume. The most common clinical causes for absolute hypovolemia are 1, acute hemorrhage, and 2, dehydration, and 3, third space fluid losses. Let's pause right here. Let you enjoy the rest of this sacred Saturday. Highest heart love. We have a major super moon coming up beginning of November. Thank you so much. We're preparing. That's right. Get our breathing right. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. When we reconvene, we have now moved on to chapter 26, shaking it up on YouTube, reading books. Thank you so much for being here and reading with us. I want you to have a wonderful Saturday. Highest heart love to all the artists, all the beautiful people out there shining your light. That's right. We're doing the work for generations now and the generations that come after us. All right. Hey, 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 hey. I love y'all. Thank you so much. Oh my goodness, this is so beautiful. I want you to have a wonderful Saturday, and I will see you soon when we reconvene chapter 26. Let's have a glass of love water for all our friends and family, all the birthdays coming up, and all those honorable people in our lives. We honor you. Live libation to the self because we love ourselves. I love you. Love you. Thank you. Love you. I love you. I love you. Oh, that's some great love water. Thank you so much for being here. Love y'all. Yeah. I'll see you soon, okay? Have a wonderful Saturday. Oh, much love. I love you. I love you. And you know it, because I love myself. Y'all have a wonderful day. I will see you soon. Peace, peace.